And nice to see you all. Before I proceed on to the main topic, could I just introduce or remind you of the combined meeting we do every Thursdays. It's been running for the last 12 months. It's by teams. It's between 10 and 11. And as Steve said, this is for any cardiology advice preoperatively. So you can send the referrals through Medway. That's what we prefer. Or you can come along and discuss the case. Even if you send them through Medway, we would like you to come and present the case if possible. Rahul and Tom Fletcher currently organizes the meeting, and I'm the cardiologist who attends, but there are plans to expand this to make it a proper MDT. The aim of this meeting is to provide you fairly quick and consistent consultant advice for cardiology-related issues. So unless you need advice straight away when you see the patient within a day or two, most of these cases can be discussed in this meeting because it's run more or less every Thursday. And by doing this, we can come to a decision fairly quickly and avoid maybe referring patients to cardiology outpatient clinics and all the delays associated with this. And we also find probably we do less investigations if you discuss these patients here. So please come along and discuss the cases. Even if you don't have a case, come along and take part in the discussion. It's a very interesting and hugely educational meeting. On that note, if I could just move on to my main topic, which is cardiac assessment for patients undergoing non-cardiac surgery. This is mostly based on the recent guidelines published by the ESC in August 2022. The previous guidelines were about 8 years old in 2014. Disclosure, I have used the ESC slide set and amended it. So that's one disclosure. I'm not part of the I'm not an author on this document, so the talk is based on my interpretation of the data presented in the document and my own experience. So it's not entirely following the guidelines, so with some modifications. Just to set the scene, about 5% of the world population undergoes major surgery every year, and 85% of that is non-cardiac surgery, which equates to roughly about 22 million procedures a year in Europe and roughly 600,000 major complications. As we know, the perioperative risk is related to patient-related risk and surgery-related risk. And if you can address it from both directions, you can significantly reduce the risk. And the outcome that we're trying to avoid by optimizing treatment preoperatively are primarily preventing myocardial infarction, both type 1 and type 2, acute heart failure, major arrhythmias with hemodynamic instability, and in-hospital mortality. So there are some general considerations within the document which most of us are aware of and largely unchanged from previous guidelines. And one is the surgical risk, and this is surgical risk depending on the type of surgery, specifically for cardiovascular events. And this is what we use for risk scoring, which I'll come to later. There is also some guidance on emergency and urgent surgeries and time-sensitive surgeries. So emergency and urgent surgery, you would proceed as normal, outside of, as you would do outside of a cardiac setting, to save life or organs. So there is no time for assessment, no time for discussion, no time for optimization. You would proceed in the best interest of the patient. Time-sensitive operations, mostly cancer-related operations, would ideally should be discussed in a multidisciplinary meeting. And that's the type of cases which are very good for our combined meeting, where we would adapt the investigations and or the treatment and not follow the routine guideline we use for elective non-cardiac surgery. So the document mostly, and my talk today is mostly covering elective non-cardiac surgery. And again, some general considerations. These are the tools for assessment. Every patient should have a history, including functional assessment and clinical examination. There are a range of investigations we can use and risk score to predict the cardiovascular outcomes. Just a few points on history, functional capacity. So the 2 flights of stairs, 4 METs is still widely used, but the current document actually promotes or encourages to use a more objective index, which is the Duke Activity Index, which has a better predictive value than the 4 METs, and it's easy to use. Cardiopulmonary exercise stress test, again, widely performed, but actually lacks evidence to predict hard cardiovascular endpoints, including mortality and myocardial infarction. ECG is a fairly straightforward and easy investigation to do, and a large study looking at this, about 23,000 patients, clearly showing an abnormal ECG is a predictor of cardiovascular outcomes in the perioperative stage, but only for patients undergoing intermediate or high-risk surgery. Routine low-risk surgery, ECG doesn't predict anything at all, but any patients undergoing intermediate to high-risk surgery, it's recommended to have an ECG done. There are various types of risk scores available, and the widely used one is the Lee index, which is also known as the Revised Cardiac Risk Index score, which provides you with a percentage risk of mortality and MI, anywhere from 4% to 15%, depending on the number of risk score available. None of these risk scores have taken into consideration biomarkers, which are new in this document and widely mentioned throughout the document. And that's from increasing evidence over the last number of years showing that two of the biomarkers, specifically the high sensitive troponin and BNP, both have incremental predictive value over and above your clinical assessment and any risk score that you use. For example, one of the studies actually showing a high troponin, which is defined as more than 14, high sensitive troponin, more than 14, in the preoperative stage, an asymptomatic patient confers almost 7 times increased in hospital mortality compared to a patient with a normal troponin. So that's a very strong message and a very good evidence, and therefore this is now widely recommended in a lot of patients, which will come into the algorithm throughout the document. The document is 100 pages long and covers all aspects of vascular disease, including cerebrovascular disease, peripheral vascular disease, PE, and also covers intra and post-operative management of cardiovascular complications. In the interest of time, I'm limiting my talk to mostly preoperative assessment and covering 5 common conditions that we come across, and the rest we can discuss at the end of the topic. So coronary artery disease or issues related to coronary artery disease is one of the common themes that we come across. Broadly, you can divide them into patients with no previous history, but high likelihood of coronary artery disease based on risk factors with or without symptoms, or patients with proven coronary artery disease, either had an acute coronary syndrome or in the chronic coronary syndrome category. In patients with no proven history, again, it depends on whether they are less than 65 and they have risk factors. If they're less than 65 years of age with no risk factors, pretty much you can go ahead without any assessment, proceed with an operation, irrespective of the risk of surgery. Except one caveat, if there is a family member with a history of cardiomyopathy, you may want to do an echocardiogram. In all other cases, if less than 65 with no risk factors, pretty much you can go ahead and do non-cardiac surgery. Over 65 and or with risk factors, if they are undergoing intermediate or high-risk surgery, would require further assessment. And the assessment is by an ECG, biomarkers again recommended in this group, and a full functional capacity assessment. If the functional capacity is normal, again, they can go ahead with the non-cardiac surgery. The functional capacity is limited. That should be guided. Further testing should be guided by the biomarkers and ECG. The biomarkers and ECG are again normal and the functional capacity limited. Still, they can go ahead with surgery, accepting a small risk. If there is abnormal biomarkers or ECG and poor functional capacity, further testing is recommended. And by further testing, we mean usually some form of stress imaging or coronary angiography. So it's important to bear in mind, although stress imaging or coronary angiogram may give you additional information with regards to the perioperative cardiovascular outcome, there is no evidence to suggest that routine revascularization improves this. And therefore, the recommendation is you should only do additional testing if this is going to really influence the perioperative management or indicated in the absence of proposed surgery. If you're doing stress imaging, there are various types of stress imaging, and pharmacological stress imaging is what is recommended. You can do an MRI scan, you can do a nuclear perfusion scan, or a stress echo. All gives similar information. In the perioperative setting, probably stress echo has a slightly edge over the other ones because a negative stress echo has a very high negative predictive value. This is just to show an example of a stress echo in a patient with a good quality image. The left-hand side is a normal stress echo, 4-chamber view with baseline and peak stress. You can see there is good improvement in contractility with improvement in function and with no regional changes at stress. And that's a very good negative predictive indicator of lack of of actually predicting a perioperative event or lack of. But on the other hand, on the right-hand side, we have a patient with some regional change at baseline, but when you stress the patient, it goes down further with LV function coming down with new regional changes suggesting possibly multivessel disease. So that's an abnormal stress echo, that's the normal stress echo. If patients have symptoms with no proven history, again, they may need some assessment before going on for non-cardiac surgery. But it's important to note that I think a lot of patients may have chest pain. Not all chest pain is angina. So you really should only be doing further tests if the symptoms are highly suspicious of angina with a clear relation to exertion and in a patient with high likelihood of coronary artery disease with multiple risk factors. And in those instances, again, the recommendation is to do assessment as you would do outside of a non-cardiac surgery. CT coronary angiogram is currently the test of choice for diagnosing coronary artery disease. That's what we would do in any patient if you see in an outpatient clinic. But in this setting, it doesn't give you a perioperative risk, and therefore stress imaging is equally useful. So any patients with symptom of chest pain, if you think it's angina, should have one of these tests done to come to a diagnosis. If breathlessness is the main problem, clinical examination and BNP are the first choice. The BNP and clinical examination is normal. You should look for other causes of breathlessness than heart failure. So moving on from patients with no proven history to those patients with an established coronary artery disease, which could be either an acute coronary syndrome or a chronic coronary syndrome. In patients with acute coronary syndrome, if they had one recently, the timing of non-cardiac surgery really depends on whether they had an intervention at the time of index event. And if they had an intervention and the timing of surgery then is dependent on when you can safely discontinue the antiplatelet treatment. In general, 12 months is ideal, 3 months is minimum. We'll come to later on actually in the talk about how you decide on this. The patient did not have an intervention or an angiogram at the time of index event. Non-cardiac surgery should be delayed for at least 60 days where there is a high risk of cardiovascular complications. After 60 days, it then falls on to the chronic coronary syndrome group. So which is the algorithm that you should follow. So the next slide goes on to the chronic coronary syndrome, which is a group of conditions, which is acute coronary syndrome beyond 60 days, a previous history of myocardial infarction, previous revascularization, or chronic stable angina proven by one of the investigation and patient on treatment. So that's the group here. They should all be on optimal treatment, which is mostly secondary prevention treatment. If that is the case, low-risk surgery, they can proceed with non-cardiac surgery, no problems. But if they're undergoing an intermediate or high-risk surgery, again, as before, they should have further assessment with ECG, biomarkers, and full functional capacity assessment. The functional capacity is normal. In most cases, they can still proceed with non-cardiac surgery, except in certain high-risk cases, particularly vascular surgery, carotid surgery, testing may be useful. The evidence is limited and not clear, and it's conflicting, but the guideline recommends to consider on an individual basis in high-risk patients with poor functional capacity, you should consider further testing. So just coming back to the stress testing and summarizing that, stress imaging, although may identify patients who are at high risk, is only recommended if you are undergoing high-risk non-cardiac surgery with poor functional capacity. And even in those patients, if the biomarkers and ECGs are normal, you should think whether it really is going to be beneficial. And the reason why stress testing is only useful in this patient is because we know that the revascularization is only beneficial preoperatively in a small group of patients where there is either refractory symptoms or evidence of left main disease. So that's a very small group of patients actually who may have high ischemic burden or refractory symptoms, and that's the group you will undertake a coronary angiography. So the recommendation for coronary angiographies again should be guided by whether it's indicated outside of the proposed surgery, and we would only do coronary angiogram if the patient continues in a stable patient, the patient has refractory symptoms on treatment, or one of the tests actually shows high ischemic burden suggestive of triple vessel or left main equivalent disease. Moving on from there, actually, one of the common questions which come across in patients with coronary artery disease is again when to stop antiplatelet agents to proceed with non-cardiac surgery. So that really depends on whether the intervention was undertaken in the setting of acute coronary syndrome, or was it a stable patient undergoing an elective intervention. If the PCI was undertaken in the setting of an acute coronary syndrome, as discussed before, ideally we should delay non-cardiac surgery for 12 months, but definitely a minimum of 3 months. Between 3 and 12 months, it really depends on the location of stent, the number of stents, the type of stents, and patient's thrombotic risk based on previous history. So that needs a further discussion. Most of the stents that we currently use, safely you can proceed after 3 months, but again, depends on the location and the number of stents, you may need some discussion. Patients having PCI as an elective procedure, ideally delay up to 6 months, but a minimum of 1 month is what is required. So if you follow this criteria, you can then decide on whether the patient can be safely discontinued from a dual antiplatelet treatment and proceed with non-cardiac surgery. I have not presented here, but the document also provides guidance on when, depending on the type of agent, you need to stop and when to restart. In general, antiplatelet agents should be restarted when the risk of bleeding is over, usually within 48 hours, then that's a recommendation. The recommendation is also there to continue aspirin in low risk surgery, low risk as in low risk for bleeding surgery. Moving on from coronary artery disease to the next common problem that we come across is heart failure in the perioperative setting. Those are the common themes which come across. So broadly, heart failure is preserved ejection, heart failure with preserved ejection fraction, and heart failure with reduced ejection fraction. Those are the two categories of patients. Heart failure with preserved ejection fraction, previously known as diastolic heart failure, is an increasing problem as the population gets older. As the name implies, the systolic function is normal, but the pressure inside the heart is high, and that's why they are in heart failure, and that is often reflected onto the atria, which are significantly dilated. And most patients may have some form of valve regurgitation as well, and most of these patients will be in atrial fibrillation. They present with symptoms of breathlessness and usually refractory edema or fluid overload and requiring multiple admissions. On the other hand, heart failure with reduced ejection fraction, as you can see here, has a dilated ventricle with reduced contractility with reduced ejection fraction, and also may have markers of the underlying etiology, in this case, a coronary artery disease showing actually problems related to regional wall motion abnormality in the lateral wall. Treatment for heart failure, again, depends on the type of heart failure. For heart failure with preserved ejection fraction, the mainstay treatment is diuretics and treatment of underlying risk factors. None of the prognostic medications or interventions so far have shown any clear benefit in this group of patients. On the other hand, if you have heart failure with reduced ejection fraction, there are a number of medications and interventions that you can offer. Obviously, treatment of etiology, and there are treatment of symptoms and various prognostic medications and device options. These are the common medications that we give for patients with heart failure with reduced ejection fraction. There are 5 classes of agents that are given normally, depending on whether a patient can tolerate based on blood pressure and kidney function. Most patients will be on a combination of this. Diuretic is purely for symptoms. All other medications do have some prognostic benefit. So what is the recommendation for a heart patient with heart failure needing a non-cardiac surgery? They all should have full assessment and ideally evaluation of LV function, if not, and BNP, if it's not done recently. And how recent is open for discussion. I would say if the patient hasn't had an LV function assessment in the last 2 years, they should have one done, unless there is a change in clinical situation. I think, you may want to see if the patient has been stable for the last 2 years and an echo done 2 years ago, probably there is no need for repeating one. The patient's clinical condition has changed, requiring further admission or fluid overload. If it has not been repeated, it would be reasonable to do one. BNP is strongly recommended in any patient with heart failure going for non-cardiac surgery. In all the other patients, if they're on optimal treatment, i.e. diuretics for preserved ejection fraction and optimal medical treatment for patients with heart failure, with reduced ejection fraction, they can proceed with non-cardiac surgery, accepting a small risk of perioperative heart failure, and therefore assessment of volume status and assessment of fluid balance and organ perfusion, including intra-arterial monitoring, is strongly recommended during and postoperatively. Moving on from heart failure to arrhythmias, usually, broadly again, tachy and bradycardias. Tachycardia, the common condition that we come across is atrial fibrillation or flutter. And most cases, the rate is controlled and they're on appropriate anticoagulation, and you follow the algorithm for anticoagulation, patients can proceed with non-cardiac surgery. It's extremely unusual to have a new onset VT which is not treated coming for non-cardiac surgery. If so, they need assessment and treatment before they proceed. But you may come across patients who already have an ICD which requires deactivation depending on diathermy use, and they require monitoring during and after the procedure till the ICD is activated back again. Ventricular premature contractions or frequent VPCs are not uncommon, and generally, if there is no underlying heart disease, no treatment is required. And if they're very frequent and for symptoms, you can consider beta blockers, but really all they need is monitoring, and the risk of developing further arrhythmia is extremely low if there is no underlying heart disease. Beta blockers can be given prophylactically to reduce the risk of arrhythmias, but not very much, not clearly evidence-based. On the other hand, bradycardia, if you have a clear indication for a pacemaker, that should be undertaken before the non-cardiac surgery. In all other cases, and this is very common, you find bifascicular and trifascicular block on ECGs in a large number of patients. Prophylactic pacing is not recommended at all. And all these cases should be monitored perioperatively with, and if there is bradycardia, should be treated with medications, including chronotropic medications, and a pacing defib should be available during and immediately post-op. Temporary pacing is purely limited for patients who are unstable and requiring an urgent non-cardiac surgery. So that's covering the arrhythmias, and moving on to valve disease. Broadly, two groups, regurgitant lesions and stenotic lesions. In general, regurgitant lesions tend to tolerate surgery very well, whereas severe stenotic lesions do not tolerate non-cardiac surgery or hemodynamic changes or volume shift that well. Recommendation for patients proceeding with surgery: anybody with suspected valve disease, if it's a new valve disease, should have a full assessment with an echocardiogram. If they're established valve disease, if they had an echo done within the last 2 years, I would not recommend. If they have severe disease, very unlikely they wouldn't have had an echocardiogram done within the last 2 years. But if you have severe disease, probably it would be worthwhile having a repeat echocardiogram. So it's only recommended actually for new cases. In most cases, otherwise they would have had an echocardiogram if they had severe disease. Mild, moderate disease, they shouldn't be having an echocardiogram if they have been done within the last 2 years. So just going on to the specific valve conditions: aortic stenosis, mild and moderate aortic stenosis, they can proceed to surgery without any further assessment. Severe aortic stenosis, as shown here, with a mean gradient consistently above 40 millimeters and or aortic valve area less than 1. That's what we qualify. That's what is severe aortic stenosis by criteria. Should be guided by whether they are symptomatic or the LV function is normal. So in severe aortic stenosis, if they have no symptoms, i.e. no aortic stenosis related symptoms, and the ejection fraction is above 50%, they can proceed with non-cardiac surgery with appropriate monitoring and avoiding hypotension during the procedure. avoiding hypotension or trying to avoid hypotension during procedure with intra-arterial monitoring, accepting a small risk of cardiac complications. But if they have symptoms or LV function is less than 50%, ideally, these patients should be considered for some form of valve intervention. It could either be a bridge like a balloon valvotomy or a permanent procedure like a TAVI or a surgical aortic valve replacement before undertaking non-cardiac surgery, provided the surgery can be delayed. Similarly, for mitral stenosis, again, if they have severe mitral stenosis, which is defined as a mean gradient across the mitral valve more than 8 millimeters of mercury with symptoms and or high pulmonary pressure, they don't tolerate surgery very well and should ideally be considered for some form of intervention before undertaking non-cardiac surgery. On the other hand, regurgitant lesions, mitral regurgitation, there are two types of mitral regurgitation. One is a primary mitral regurgitation where the problem is in the valves, prolapse in this case causing mitral regurgitation, or could be secondary mitral regurgitation where the problem is in the ventricle and the valve is leaking because the ventricle is not contracting well. The management is different for primary and secondary mitral regurgitation. So secondary mitral regurgitation, the problem is in the ventricle. The algorithm you should follow is that for patients with reduced heart failure with reduced ejection fraction, they should be having treatment for underlying etiology and should be on optimal heart failure treatment before undergoing non-cardiac surgery. Whereas for primary mitral and aortic regurgitation, unless they are severe with symptoms or evidence of significant LV dysfunction, they all can proceed with non-cardiac surgery. As I said before, regurgitant lesions or primary regurgitant lesions are well tolerated during non-cardiac surgery. So even in patients with symptoms and severe LV dysfunction, the class of evidence for recommending anything to be done prior to non-cardiac surgery is not class 1, so its evidence is not that strong. And most cases, they will tolerate non-cardiac surgery well. So moving on from valve regurgitation to cardiomyopathies, there are two groups worth mentioning. One is dilated cardiomyopathy with reduced ejection fraction and hypertrophic cardiomyopathy. So dilated cardiomyopathy, essentially, the algorithm is that of heart failure with reduced ejection fraction. Again, you should treat the etiology for the cardiomyopathy. They should be on appropriate medications, symptomatic and prognostic medication, and possibly device consideration should also be given, as with heart failure with reduced ejection fraction. Hypertrophic cardiomyopathy is not uncommon. The incidence is 1 in 500, so it's not uncommon to come across hypertrophic cardiomyopathy patients requiring non-cardiac surgery. Classically, they have asymmetrical septal hypertrophy, as you can see here, thickened septum, which then causes what we call a systolic angioedemotion of the mitral valve, resulting in LV outflow tract obstruction. There is obstruction in the LV outflow tract, you can see here, and then secondary mitral regurgitation as well. Those are the classical features of hypertrophic cardiomyopathy, but not all patients will have all the features. So the perioperatively or intraoperatively, the risk is mainly increasing the LV outflow tract obstruction and causing hypotension. So therefore, to avoid that, you should make sure the fluid balance is optimal, keep the left ventricle full, and avoid inotropes, avoid vasodilators, and keep the heart rate low as possible. If you do that, most patients tolerate this without much problem. If they develop hypotension during operation, you could do an assessment, but most cases respond to fluid balance or fluid challenge and or avoiding vasodilators, inotropes, and possibly some beta blockers. The document also gives you some general considerations, and one thing is actually smoking cessation 4 weeks before the recommended surgery does reduce postoperative complications and mortality. Also gives you a recommendation on what medications you should continue and discontinue. So beta blockers and statins ideally should be continued if the patients are already on them. Diuretics and SGLT2 inhibitors, which are dapagliflozin and empagliflozin, which we commonly give for patients with heart failure, ideally should be discontinued before non-cardiac surgery. There is also controversy on whether routine initiation of beta blockers is useful in patients undergoing surgery. Previous guidelines suggested actually it may be beneficial, and that's based on one trial showing there is clear benefit in reducing mortality if you routinely give beta blockers, but another trial actually showing there is an increase in mortality. It may reduce the myocardial infarction, but they reduce the mortality. There is an increase in mortality if you give beta blocker, possibly related to hypotension. But if you take the overall evidence from all the trials and meta-analysis, there may be a case for routinely giving beta blockers in high-risk non-cardiac surgery where patients have more than 2 clinical risk factors. Again, the class of evidence is not 1, it's 2B. And if you're giving beta blockers, you should give well before the non-cardiac surgery, not in the last 1 week, ideally 2 weeks before. And bisoprolol and atenolol are the 2 medications that are recommended. And you should try and make sure that patients do not have hypotension related to beta blockers. So there is this somewhat, very unclear evidence of routinely giving beta blockers in high-risk patients who are undergoing non-cardiac surgery, even if they don't have an indication otherwise. So in summary, the guideline, not a lot of changes from the previous guideline, but actually, summarizing that, I think all patients undergoing non-cardiac surgery should have a full history and clinical examination, including functional capacity assessment. Biomarkers are new in this document, has got a lot of evidence and widely mentioned, and ECGs and biomarkers are strongly recommended for every patient over 65 years of age and or with risk factors and or previous cardiovascular disease. And further testing is to some extent is guided by whether they are normal or abnormal. And as I said, a positive troponin in the preoperative stage, even in an asymptomatic patient, is a strong predictor of mortality. Now, we have very limited experience. We haven't done this actually through our meetings at all, but something we need to look into. Transthoracic echocardiogram, according to this document, is limited to patients with a new murmur with symptoms or patients who are at high risk with poor functional capacity and a high BNP. I would say actually you should also consider transthoracic echocardiogram if you're detecting new onset atrial fibrillation for the first time and or multiple VPCs for the first time or a new left bundle branch block. But I think the guidelines assume that those patients would have had an echocardiogram otherwise. So it also applies to patients with established heart disease like heart failure and valve disease. Most of these patients would have had an echocardiogram in the last 1 or 2 years where you may not need to repeat one. A new echocardiogram is indicated in these patients. So based on the risk assessment and the baseline investigations, then there may be a small group of patients who may need further testing, which is stress imaging with either stress echo or even smaller group who may require a coronary angiogram. But that's, again, should ideally be done only if it influences the perioperative management or is indicated outside of the proposed surgery. Because although they may give you further information regarding perioperative management, routine revascularization lacks evidence in optimizing the patient before surgery. So time-sensitive operations and complex cases and should ideally be discussed in a multidisciplinary meeting. So most of the recommendations are really for elective cardiac surgery where there is time for discussion, doing investigations and optimizing the treatment. And please don't forget the joint cardiology preoperative meeting. Come along and take part in the discussion. Thank you.